Okay, welcome to our live stream. I'm Dr. Deuk Majan. We are getting ready to perform a thoracic Deuk laser disc repair. Thoracic. Our patient has had extensive fusion surgery. We talk about fusions all the time, how you should avoid them. Just take a look at her x-rays. She travels here from Washington State. And she has had fusion from, I don't know, it looks like T9, 8, 9, or maybe 9 or 10, all the way down to her sacrum. She has now what's called junctional failure, where she has a fracture above her fusion. You're going to see that. The surgeon went in and did kyphoplasties at the top 3 levels. That's where he put cement there. It didn't work. And now here she is. She doesn't want more fusion. She has a herniated disc. She's got facet pain. We're going to be going in and treating her disc as well as her facets to try to give her some pain relief. She realizes that's not going to be the final solution for everything, but she wants some relief and we want to give it a try, and I think it's going to be very helpful to her. So we'll see. We're also going to be doing a piriformis release a little bit later on her left side. Our first patient is doing fantastic. Yes, I agree. Shot? Okay, so for those of you that are watching the x-ray, you see 2 little eyes. Those eyes are kyphoplasty cement put into her vertebral body by her last surgeon who did all the fusion. Lateral. Folks, this is why I don't want you getting invasive spine surgery. It leads to fusion upon fusion upon fusion. Show us the hardware. Zoom out. Just do a quick zoom out and come south. Yeah. Look at all the metal, guys. Come south. Let me show you. Hold on. Shot. All right, table up a little bit or fluoro down, whichever one. Shot. Folks, this is the hardware I'm talking about. The screws and rods and cages. This is what you want to avoid. This is what happens when these spine surgeons these days get a hold of you and they just start doing fusion after fusion, laminectomy, discectomy, fusion, pain management, and pretty soon you've had what she's had, multiple fusions, and you're a complete mess. All right. We're going to be doing arthroscopic surgery. I'm going to get in there and treat that. You can see the fractures in her spine, right? Show us the fractures, Jordan. Fracture there. Go up and down. There you go. Fracture there. Fracture there. Fracture there. Each one of the fractures has cement in it. And that was put in by her last surgeon that did all the fusion. Shot? All right, we need to get into that disc right there. You can see it. How is her ventilation? Shot? Uh-huh. Shot? All right, let's go AP. So the first thing I'm going to do is gain access to the disc here right above her fusion. And that is the disc we're targeting. Now, if you look at a report, some radiologists call it 9-10, some call it 10-11. It doesn't matter. We call it the bad disc right next to her fusion. So that's what we're targeting. Let's go, Jordan. Any questions from the audience?
No current questions.
All right. Yeah, it's unfortunate to see all the surgery she's gone through. It's just totally unnecessary in my opinion. Shot? And to do that on a patient with osteoporosis, right? Now we've got to get past this bone to get to that disc. Shot? Let's go AP. Let's see where we are. I'm trying to navigate my needle down to the disc, and I'm going to go transforaminal. I'm a little bit too medial. I can go a little bit more lateral. I don't necessarily want to start more lateral. I want to stay where I'm starting and just aim a little bit more lateral. Shot? She's got a lot of bone spur here. Shot. All right. We're making a little bit of progress. Shot. A lot of bone from her fusion. I just have to be really careful. She has osteopenia, osteoporosis, and I got to be real careful around her bone. Shot. Let's get an AP. All right, so things are looking good. You can see the tip of the needle just above the screw. I could be just a little bit more lateral, and I think I need to be.
I got her a little deeper right now.
Shot? No, from an anesthetic standpoint, I think she's perfect. Yeah. Shot? She's not moving at all.
I don't know about the evocative disc. I'll do my best to turn it off.
Yeah, well, I'm almost there. Shot?
I'm gonna turn it.
Shot? Cervical. Shot? AP? All right, we're almost there. I may have to start a little more lateral. Let's see how things look. Nope, it looks pretty darn good, actually. I'm surprised. It's looking good. Can you introduce the pedal when I'm ready for it, not before? I know it's easier for you to just stick it there, but it creates a tripping hazard. All right, shot. Shot. Now we're inside the disc, so we've successfully accessed the T. And again, I'm referring to it as T9-T10 or T10-11 because the different radiologists refer to it differently.
You doing all right? We're going to ask you a question now, all right? Okay. Dr. Deuk's going to ask you a question.
Really? None? Are you comfy?
Are you comfortable?
She's awake. She's helping us. Are you having any pain?
Are you having any pain right now? Where? The spot where you worked.
Uh-huh. Are you having pain right now? How bad is that on a scale of 1 to 10 right there?
Give us a number. 10.
Is that where you typically get your pain? Congratulations, we found your pain source. It's that disc above your fusion, just like we thought. All right, so she had 10 out of 10 concordant pain. At what level are we doing? What are we calling it? T9-10, yeah. Time to go 99. Okay. She had 10 over 10 pain. It was concordant. Concordant means that's the pain she gets every day. So she just confirmed that the disc we're fixing is the one that's causing her pain. So we're putting a guide wire shot. And I'm going to give her some num-num. We're going to make a small 4-millimeter incision. If you have questions, feel free to ask. But this is a patient who's had pain in her thoracic spine above her fusion for years. She doesn't want more fusion done. And she saw our laser surgery. And she saw that we've done a little over 20 patients with thoracic herniation safely. And we had 99% elimination of that pain 1 year after surgery. We actually published those results. So she decided to fly here to Florida from Washington State to get this surgery done. And we're doing it arthroscopically, transforaminal. We're the first in the world to do this in the thoracic spine. And we're the only ones to do the Deuk laser disc repair, which is an annular debridement. All right, shot. Now I got to be careful. You see all the fractures in her spine. She has what's called junctional failure. She had this big fusion, multiple fusions, and then it put so much stress on her spine above the fusion that everything just fractured. And the surgeon stuck all this cement in her bones. You guys are seeing it looks like black cotton balls inside the bone. And, yep, thank you, Jordan. There's 3 of them, so 3 fractures. So the surgery had major complications with fractures. Now we're trying to fix the pain source right above. She's in debilitating pain. Questions for me?
Yes, these next 2 questions come from Bo on Facebook. And first question they ask, when you take the laser out of the disc fragments, does the space always stay open or does it fill in?
When the laser removes the fragments of disc herniation, the space stays the same. It doesn't get worse, it doesn't get better. We're not changing the space. Shot? In other words, man, it's tight. We are not changing the space at all. We're just taking the herniations out.
This next question, I think they repeated their next question, but this next question comes from Jenny on YouTube, asking, could 2 thoracic disc bulges still be causing pain because other doctors say they're no big deal?
Yes, they are the cause of your pain. And we can fix it for you at Deuk Spine Institute. Jenny, you need to come here. We're the only ones in the world that do this. You either live in pain the rest of your life or you come here and have exactly this surgery on those 2 discs. Now, to see if you're a candidate, which it sounds like you are, you're going to want to do our free MRI review. You can do it from your home. You don't even have to come here to do it. But it's best if you do come here so I can verify that they are the cause of your pain. This is the only cure in the world for those thoracic disc bulges. And the reason the other doctors say they're no big deal is simply because they don't know how to fix them. And they don't know that they're causing pain. But that's what we do at Deuk Spine. We find the source of pain and we cure it. All right, I'm placing the tube into the disc. We're in. And yeah, there's no way I could get the larger scope in because her disc is so collapsed, but also she has the fractures. Thank you, Luis. Okay, we're ready. We're inside the disc. We know this is the cause of her pain. She had 10 out of 10 pain. We're also going to fix her facet joints because she has facet pain. We're going to do that next. And the last thing we'll do is a piriformis release because she's also having piriformis pain. So she decided, hey, I'm going to go to Deuk Spine and get everything fixed. Now she does have one more cause of pain, her SI joint, which we offered to treat, but she didn't want to get it fixed. But that's also a common cause of back pain, SI joint, sacroiliac joint, for those of you who don't know. We are inside the disc. You can see it right there. It's actually a beautiful view. The people that are doing our scopes are doing a great job, Luis. This is a thoracic disc surgery, thoracic Deuk laser disc repair. It is not a discectomy. We're not removing the disc. It is a repair of the disc. It's called the Deuk laser disc repair. This treatment was pioneered at Deuk Spine by myself. I'm Dr. Deuk Majan, the founder. And we've been doing this surgery now for 17 years. We've done 1,900 surgeries in 1,900 patients. The average of 2 discs per patient. So I've now treated, it's not 2, it's 2.2 discs per patient. I've treated about 5,000 discs endoscopically. Most people would call this a degenerated disc, and it is. It is degenerated. Any questions?
No current questions.
Henry, let's show the audience, how does a disc injury cause so much pain? What's the mechanism? Okay, welcome back. We're trying to get our tube to work. So far, everything's going good, except we have the tube is not engaging with our fluid adapter. So we may have to change the tube out. Is it moving? No? Nope. Let's go, Jordan. Come on in. Get me a new tube. Let's go, Jordan. Come on. Stop moving like an old lady. Mallet. Shot. Shot. Perfect. All right, we got to get this part out. So let's get the fluid adapter back on. Just lay still. Yeah.
You're doing great.
Yeah, see it engages nicely now. Shot. Yeah, I think we just need to change it out. Shot. It's weird. It's like grabbing this tube as well. Shot. Is that it? Shot. Yeah, that's nice. Thank you, Luis. Shot. Wonder if I can just shot. Hold on now. Shot. 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 Let's take this out. Just shot. Let's get a scope in and see. Yep. Thanks, Jordan. I think she was just tight compressing and squeezing on the tube. I mean, I still think the tube needs to be, repaired, but yeah. Huh? Yeah, it's working. I mean, but the tube still needs to be repaired. But this is where we need to be. This is good. Henry, any questions so far?
Yes, we have a question. This comes from Bo once more on Facebook.
Uh-huh.
Asking, I did a talk with you, doctor, about a year or two ago with my MRI. Insurance didn't want to pay so much, but I'm going to try again. But my question is, do you want a new MRI, or can you use the ones from 2 years ago?
Yeah, it's a great question, Bo. Here's the answer. If your symptoms haven't changed and they're about the same, then you don't need a new MRI. We can use it from 2 years ago. It never hurts to get a new MRI. If your symptoms have changed, gotten worse or whatever, then I would definitely get a new MRI. And I can order it for you. I'm feeling wet on my feet.
Is the suction on in this drainage?
It's not suction, it's running around on my hand probably. It's just leaking out on my hand and going down my elbow.
Like the last.
Huh? Yeah, what needs to happen is we need a cloth to trap the liquid so it doesn't go down my hand.
Thumb and going into your wrist.
That's what I'm saying. And then it goes down my sleeve.
Right.
And then it drips onto my feet. So we have to capture it coming out of the tube. All right, very good. Almost done. And then we're going to move from the disc repair to do the facet treatments, because she has not just disc pain, she has facet pain. So she her case highlights an interesting fact, which is that most patients with back pain have more than one cause. As a matter of fact, it turns out from our data that we've looked at in 500 of our patients with back pain that only 10% have one cause. The other 90% have more than one cause. And as a matter of fact, 20% have 7 or more causes. 7 causes of back pain. That includes facet joints individually, discs, each one individually, piriformis muscle, SI joints. And by the way, the most common cause of back pain is the disc. It's called a disc injury. You guys know about it as a herniated disc, but it could also be a bulging disc, a ruptured disc, an extruded disc, a protruded disc, a slip disc, a degenerated disc. All those names are disc injury names, injury to the disc. And it's disc injuries that cause back pain turns out at 87% of the time. The chronic pain is coming from a disc injury. And if you do the Deuk laser disc repair surgery, this surgery, then you get rid of, on average, 99.6%, which is basically 100% of the discogenic pain. Discogenic means the pain comes from the disc. That's our average with our patients. Now, if you get rid of disc pain, but the patient has some other pain source, like their piriformis muscle, and we didn't treat that, then they're still going to have the piriformis pain. So what a lot of people get confused about is they'll have the disc surgery, then they'll have pain afterwards somewhere else, and they call it back pain, and it is part of their back. They're right, but it's not the same pain. And most people recognize that, hey, this is not the same pain that I had before. It's a different kind of pain. And the reason why is that, to be honest, just because you're having pain somewhere today doesn't mean you'll have it there tomorrow, right? So everybody's pain kind of fluctuates. And there are days when you have it. Please put it around my wrist. That's the problem. You don't put that cotton around my wrist anymore.
I put on the wrist over here.
Yeah, but it's traveling from my hand. Somehow it's getting on my feet. My shoes are getting wet. And this water is very cold, by the way. We want it cold. It keeps the tissues from getting hot and burning. We talked earlier, last surgery, about how the laser doesn't burn. It basically delivers energy to proteins and breaks up their covalent bonds, called peptide bonds. It works on a molecular level, but it also can heat the tissues. And we don't want it heating the tissue. We want it flip. We want it not heating the tissue. So we put cool water around the tissues all the time. And that's why you're seeing like this liquid. That's just saline, sterile saline, cold. We keep it refrigerated so that it's, 8 degrees Celsius, 6 degrees Celsius? I'm not sure. Anybody know the temperature on the refrigerator? It's cold.
Yeah, it's very cold.
Huh?
It's very cold.
It's cold.
Yeah.
Not cold if you're from South Dakota cold, but cold if you're from most places in the South cold. Maybe it's warm for Alaska or Siberia, where Luis is from.
You ever watch that National Geographic show, 40 degrees below zero?
No.
Really interesting show.
Really?
Yeah, it's kind of a documentary of different Eskimo tribes and families and where they live in the state of Alaska
Really?
and how they provide for themselves.
Huh.
Different types of hunting, fishing strategies.
Yeah. Dr. Berndes is talking about
I thought it was a great show.
a National Geographic show. How are we, Flip? Luis, where are you running off to? You're killing me. All right, Henry, any more questions? We're just about done. I need another minute probably. You can see we've gotten rid of all the herniation, cleaned the tear. This is the end of it right here. You can see the vein right there at the bottom at 6 o'clock. It's pink. That's an epidural vein sitting on the outside of the disc.
Her blood pressure's perfect.
Thank you. Dr. Berndes said she's very stable, hemodynamically stable. Nice lady, been through so much. I feel so badly for people like her, and I keep trying to get the word out. Stay away from invasive back surgery, folks. The surgeons love it when you have invasive surgery because it pays them really well, and they know you're going to be coming back for more. You're like an annuity to them, and that's all they care about is making as much money off you as they can. Unfortunately, you're just going to be living in pain and having procedure after procedure. We've seen it time and time again. You're going to want to get something done definitively where you're fixed and you're out of pain permanently. And not many people can offer you that. Oof. All right, I think that's it. Just wanted to triple check. Any questions, Henry?
No current questions. We just have a thank you from Bo for answering his question earlier.
You're welcome, Bo. Yeah, the insurance stuff, we don't like taking money from people, but we have to pay our bills. And if the insurance won't pay, well, we got to get the money from somebody. Unfortunately, we don't have anybody donating money to us. I've tried to get some of our rich patients to donate, but they don't. They don't want to. It's like people just want to take care of themselves. Yep. I would love it if we could get some wealthy person to actually do something of significance and help people out. So we didn't have to take money from patients. The other thing is we got to get the insurance companies to stop, doing whatever they want to do because they don't want to pay for people's medical care. They would rather people suffer. All right, we're done with the Deuk laser disc repair. Next is going to be the Deuk plasma rhizotomy. We're going to bring the x-ray machine back in and we're going to find these facet joints that are causing her pain. We're going to go in and treat them with what's called a rhizotomy, which is where you basically cut or deaden the pain nerve to the joint. Now, I didn't come up with the rhizotomy procedure. It was invented by somebody a lot smarter than me. But the tools that are being used, folks, this is going to blow your brain right here. The way rhizotomies are done, they're called RFAs. They're done in such a way that basically you have to keep coming back and getting it done over and over again. And shot. And guess what? That works just fine for the doctors. And that works just fine for the company that sells the rhizotomy equipment. They love the fact you have to keep coming back. But you know what that doesn't work well for? You, the patients. Why would you want to keep coming back, getting a procedure done over and over again every 6 months? So I asked the question, why?
We're happy just to get a Christmas card from our patients.
Right? We're happy just to get a Christmas card. We don't want you coming back having procedures redone. So I asked the question, why does the RFA not work permanently? And I learned the answer. I figured it out. Basically because it's not burning the nerve properly. It's just stunning it. And the nerve just grows back. As a neurosurgeon, we know you can destroy a nerve so it never grows back. So why aren't we doing that? That was the question I asked about 2 years ago. I said, why are we not doing this on a permanent basis to give patients permanent relief? And I looked at the situation and I realized why we're not doing it on a permanent basis. Because the doctors doing these procedures are not surgeons. They don't know how to do it permanently. They only know how to stick a needle and do it temporary. She's fine. That's when I realized we can actually do this permanently. But you need to do it the right way. You need to actually cut the nerve, not just stun it. Shot? And that's when I developed the Deuk plasma rhizotomy. The Deuk plasma rhizotomy actually destroys the pain nerve permanently. And I honestly, I scratched my head and I said, why didn't anybody else figure this out? And I realized why. It all comes down to money. You see, why would you want to cure somebody's thoracic pain or facet pain when you can have them keep coming back over and over again? And that's the problem, is a lot of these doctors don't want their patients cured. They just want to keep treating them. That's why pain management is called pain management, because you're going to have to keep coming back. How's their ventilation? Just verify it for me now that we're done with the right side. Will you just triple check the right side? All right, good. So we're done with the DPR on the right. Now I'm going to go to the left and I'm going to repeat the DPR procedure. Shot? Yeah, let's go. Yeah, no problem. Take that. Go ahead. Questions from the audience?
No current questions, but we do have a comment from Canes25 on YouTube.
Page 25.
He said, what a case, doc. I pray this woman gets relief.
She'll get relief. Thank you, though. Very kind of you. Yeah, I know. It's sad, isn't it? You see all the screws and rods that the surgeons put in, multiple surgeries over time, just unfortunately using people for their insurance policies, just pumping the metal in. By the way, every one of those screws, folks, is $1,000. $1,000. That's $1,000 paid to the company that makes them. Those companies want surgeons putting those screws in you. They encourage it. They take you out to a steak dinner if you do enough of it. They offer you things like, be a speaker, we'll give you money. You know, it's no joke. I was part of that system. I was fully aware of it. I was offered all the goodies. And I said, this is wrong. Patients should not be getting metal when they don't need it. So we've made a change. And we're doing endoscopic procedures now, minimally invasive, that patients don't need metal. Shot? Any questions?
No current questions.
We're going to be done in just a minute. Shot? All right, Henry. Why don't you, let's do this. Go ahead and cut the stream, and let's get ready for the piriformis.
Copy that.